Dr. Neal Halfon is both a medical director and also has a master's in public health. He's the director of many things. He's the director of, we got your presentation up. He's the director of the UCLA Center for Healthier Children, Families, and Communities. He also directs the Child and Family Health Program at UCLA's School of Public Health and the National Center for Infant and Early Childhood Health Policy. He's a professor of pediatrics, also teaches community health sciences and public health, and is affiliated with RAND's program in public health as well. We're very thrilled to have Neal here with us today, and as many of you know, he's really the pioneer in the movement here in the United States for Life Course, and the development of the model here in the United States. And then I have to say, if you haven't noticed in his bio, he also has worked with former Vice President Al Gore on domestic policy and healthcare issues. So we're thrilled that Dr. Halfon is here with us today, and I think you're going to really enjoy his presentation. So come on up, Neal.
Good morning. Can you hear me on this? Is this on? So you can hear me okay? All right. Because I can't see my slides from here, so I'm going to probably stand over here. Hopefully that'll work. I want to tell you a little bit about my story. It's not quite as dramatic and possibly as relevant. But I started off as a pediatrician in Oakland, at Oakland Children's Hospital. And part of what I did there was work on, I started something called the Center for the Vulnerable Child. And the Center for the Vulnerable Child was about taking care of children who had grown up in conditions of adversity. And what we tried to do was really figure out a different way of dealing with kids who had been either abused or neglected, kids that were born to moms who were using drugs at the time, or teen moms that needed more than average kinds of health care services. And what we did was, and it's quite relevant to the story that you just heard, we really tried to deal with the kinds of traumas that children had and created a multidisciplinary team with infant mental health workers and home visitors and developmental pediatricians and others, so that we could provide a kind of holistic, integrated approach to children who have been traumatized and to their parents. And I was lucky at that time to work very closely with Jeree Paul and Sally Province. Jeree was the head of the infant mental health program at San Francisco General, and was the heir of Selma Freiberg. And some of you might know Selma Freiberg wrote the book about the ghost in the nursery, which is exactly what we heard just now. But it was really thinking about the nature of trauma and how deep trauma is, and the way that it impacts children in their development. I ended up doing this work there at Oakland for many years and got very good at putting Band-Aids on boo-boos of kids that were harmed in one way or another. But I realized that if we were going to really deal with these issues, there weren't enough pediatricians, there weren't enough Band-Aids. That what we really needed to do is move upstream and figure out why were these kids being affected. And rather than using the little levers that I had in my black bag, my otoscope, my various things that I had that I could carry with me, I really needed to think about what are the big levers that we have as a society to actually change, to move children out of harm's way, to move other people out of the traumatic situations they are, to change the kind of conditions that people live in. So what I'm going to talk to you today is about big picture issues. I'm going to talk about a way of thinking about health and health development in a different way, and a way of really taking advantage of where we're at in a very important historic time in terms of transformation of our health system, so that the issues of mental health, and specifically maternal mental health and children's mental health, we start to think about it from a life course perspective. And we start to understand that the trauma and the adversity that people have experience can be deep and long-standing, and can reverberate throughout your life, and can compound over time and lead to the kinds of issues. And so that we need to be thinking about not just intervening during pregnancy or prenatally or preconceptually, but really right from birth, as we've heard. So that was a great sort of lead into what I'm going to talk about. But I'm going to start real big picture, and then I'll zoom in. I'm going to talk, and part of what I'm going to do is I'm going to talk a bit about adolescence, because I'm going to talk about how there's sensitive periods of development, and adolescence is a sensitive period of development. But I'm going to focus on how much mental health problems develop during adolescence and how we're missing the boat. And from an American healthcare standpoint, that adolescence is actually a critical period that we're missing the boat on at present. So we have the most inefficient, low-value, low-return on investment healthcare system in the world. That's good news, right? And we have this policy right now called the triple aim, which is to improve population health, improve quality of care, and lower the cost. That's what our national policy is driving HHS. We have a number of other challenges in terms of getting our health policy right. One has to do with enormous disparities in health outcomes and growing social gradients. As inequality increases, what we're seeing is really big problems. And we have rapid rising rates of chronic disease that are happening in the United States. We have unavoidable demographic shifts. That means that our population is getting older and older. It's the first time in human history that we'll have the old people outnumbering the younger people. That's a big problem, when you start to think about things from a life course perspective, because you don't have the money to invest early in life because it's all flowing to the other end of the lifespan. And we have these relentless cost increases. We also have an anemic, tired old health policy that does not reflect what we understand about what produces health. And it's sort of trapped in not only the last century, but about two mindsets past. And we're having a hard time changing that because a lot of people make a lot of money using the old model. And it's hard to change people's ideas when their livelihood and their pocketbook depend upon them. And so we have this old, outdated operating system. And part of the issue is a lot of you out there are developing new apps for maternal mental health and new apps to intervene early in the life course, but we don't have an operating system to run those apps. We have lots of one-off little programs all over, but we don't have an operating system that we can put them on and just let them run and spread and scale. So part of what I'm going to be talking about is how do we change the operating system? How do we reframe this issue? How do we think about it in a different context? So this is just to show you that the United States is up here compared to other countries. All healthcare costs are going up, but we're twice as expensive as all the other advanced industrialized countries. This is just to quickly show the United States sits down here. This is healthy life expectancy. We're down at the lower end of the spectrum. You've heard that we're 34th in infant mortality and all kinds of other statistics. What we also know is the biggest cost drivers in our country is chronic disease. 75% of all overall healthcare expenditures go to chronic disease, and 83% of Medicaid expenditures. That's really important for us to know because Medicaid is what pays for most births in the United States for poor women, pays for most of the care for children, and most of the dollars in Medicaid now are going to elderly people with chronic illnesses. And because we have no social mobility in our country anymore, about 40% of people that are born in the lowest quintile, meaning born poor, will remain on Medicaid for their entire lives because they're not going to move out of poverty their entire lives. So that we have this growing issue. It's another important public policy issue. This is just looking at the change, and what you see is that from 87 to 2005, based on national data, you see that we've had a threefold increase in the number of people with mental health issues. This hyperlipidemia is probably a Lipitor effect, meaning that once we got the drug, everybody had hyperlipidemia. Hypertension, but you see that all these things are going up. So we have these increases, that are happening. I think what's really interesting, there's stuff in the pipeline, right? There's stuff happening in the pipeline. We just heard recently that lung cancer in women is actually now more prevalent than breast cancer. And that's because all the women that were smoking in the 50s and 60s and 70s, that's now, we're now having to pay the piper on that in terms of what's happened. There was an Institute of Medicine report that was done recently on why the United States is the sickest of rich nations. Why do we have the worst health and the highest cost? And two things that came out of that report, and I really recommend just looking at this because it's really quite startling. Two things that came out of that report. One is when they looked at all the rich nations and compared them, the reason why we have the highest costs and the worst health is that we spend the same amount of money, health and social and education services as all the rest of the countries. We're all spending about the same. It's just that they spend their money on social and education services, and we spend our money on health care. They spend their social and education services early in the lifespan and make an investment in the success of the healthy development of the population, and we pay for failure once people are sick at the other end of the lifespan. So it's a completely different way of approaching what we're doing, and we're coming out, short on this, and we're short in a whole variety of ways. And it's important to recognize is that when countries spending close to 18% of their GDP on medical care after the fact, after people are sick, you don't have as much money to put into education and all these other things. So we're starving ourselves in terms of the funding that we need. The other thing that this report came out and showed was, and I show it in this thing, and you're not going to be able to see this, but this is Netherlands, Norway, Iceland, all the way down, and here's the United States here down at the bottom. This is looking at the health of children in the rich countries, and what it's showing on 45 different indicators, that the United States, here's health and safety, we're 25 out of 29, we're 26 out of 29 on the material well-being, behavioral risk, we're 23 out of 29. So we're down at the bottom of the barrel here in terms of other countries. And what it indicates is that if you start off, if your kids are sicker than everybody else, your country's going to have worse outcomes. So we start off behind, and the die is cast, so to speak. The reason why our country is sicker and not doing as well is that we're missing the boat early on in life. So when children fail, everyone pays, and we know that when children fail early in life, you get school failure and additional costs due to expenditures for second chance programs. You get diminished potential to form strong relationships. So that means that families don't form, or when families form, they don't stay together, and we pay for that in various ways. There's long-term costs and social dependency. There's issues that have to do with the increased productivity and lifelong health problems that also. So we all pay when we're not, doing what we need to invest in our children early on in life. And it's actually pay now or pay much more later because of what happened. So when we look at how our children are doing in the United States, well, mortality rates continue to decrease. That's great. There's less kids dying of bad things. And morbidity of many medical conditions has gone down, so the number of kids with pneumonia and meningitis and gastroenteritis has all decreased. But their disparities in health outcomes are actually increasing in our country because of the growing inequality. And we have all these new conditions that have happened, and the patterns of exposure and risk are changing rather dramatically. And we're not paying attention to this. When I showed you that the mental health of the population has increased almost threefold over 20 years, I'm like, what is going on? Obesity's gone way up. What is going on? What's happening? We're like, the old adage of, putting the frog in the pot of boiling water. If you turn up the temperature slowly, it just sits in the boiling water and boils. Throw them in, they jump out. Well, we're sort of turning up the temperature slowly, and we're not paying attention to what's happening in our social conditions and the lives that we live and the kinds of conditions in which children are being raised. And we're well aware of the obesity epidemic, and we're trying to make adaptations to that in various ways. But what we see is that we have an increase in chronic health problems in children, and it's not hemophilia, it's not cancer, it's not congenital heart disease that's going up. What we're seeing is that we're seeing increased prevalence of mental health problems in children. We have 20+% of kids that have mental health problems with impairments at present. That's a fifth of the children have mental health problems with impairments. So why do we have more women with, postpartum depression? Because the pipeline is, getting filled with more girls that have mental health issues as girls also. We have greater appreciation for the role of developmental issues, and growing numbers of children with multiple comorbidities have asthma, obesity, and ADHD. And so you have to ask, why are kids getting all three of those? What's happening? Is it a change in our genes? Probably not, right? Our genes aren't changing. So something's happening in our environment that will allowing these things to happen. One of the things that I think leads to the asthma, obesity, and ADHD is toxic stress or different kinds of stress. It's interesting to see that the obesity epidemic actually parallels the number of single-parent families. And there's actually evolutionary biology literature that shows that in certain animals, when a father's missing or a father's killed in the animal pack, that what happens is the female animals start putting on weight and puberty advances rapidly because they're not being protected. So maybe obesity epidemic isn't all about just calories in, calories out. It has also to do with the social conditions are being. This is looking at trends in disability in children. What you see here in the National Health Interview Survey, this is research that I've been doing for the last 25 years. You see that 2% of children were classified as being disabled in 1960, and now we're at 2008, we're at about 8%. So the number of children with disabilities has been steadily rising, okay? Are you aware of this? Did you know this? Okay, so you're hip to what's happening here. What does this look like? The poster child for disability in 1960 was a little girl with braces on her legs and crutches because she had polio. The poster child now is a little boy with autism, right? A complete shift in the kinds of conditions that we have. So if we look at the children that are at risk at present, we have 4 to 6% with severe disabilities, 12 to 16% with special health care needs. We have 30 to 40% of children that have behavioral learning problems and mental health problems. That's a huge number of children. That means that our healthcare system isn't designed to take care of this, because just think about health insurance. Health insurance was designed basically to take care of stuff from the neck down, right? Didn't cover the antals, meaning the mental, developmental, and dental. None of that was, part of health insurance. So we're now covering that, but we don't have the services in place for everybody at present. And we have about 50 to 60% of kids that are good enough. And I won't go on about that, because unless you have teenagers, that's not what you focus on. You sort of want your kids to thrive, right? So we really want to know what percentage of kids are thriving. So what's important to recognize also is look at the number of kids living in poverty in the United States. This isn't the federal poverty level, but what we know is that if you're living under 200% of poverty level, you don't have enough resources to thrive as a child. So we have half the population of the children are exposed to high-risk conditions that make it hard for them to not just to survive, but to thrive and to actually reach their full potential. And what we know about economic adversity is children are born early, smaller, more fragile, at risk, worse physical, emotional health, hospitalized more for a whole set of conditions, have lower health trajectories, carry the burden of their social status with them for the rest of their lives because it's being programmed into their biology, into how their immune system functions, their endocrine system, their neurologic system. This is what this life course model is about. Those exposures and adversity early on in life throughout your life so that it becomes a burden that you take with you. So we have this ideal trajectory here of children that could go in an ideal trajectory, current practice, and we have this enormous missed opportunity in our country. And our country is all about opportunity, and we're hearing Jeb Bush talking about the opportunity gap. Well, this is really the opportunity gap. Not just an economic opportunity, it's a human development opportunity gap. So with these new challenges, there's new paradigms and new strategies. So I want to talk a little bit about what's going on with Life Course. And there's ways in which the healthcare industry is starting to understand this. This is from Blue Shield ad. And what you see here is they're sort of making the connection between early life and later life and sort of making that connection. My grandmother and now my mother could tell you about life course, because they watched people grow up and they knew what happened early on in life affected them. Every novelist knew that, because that's about human narratives are all about the traumas that people have and what happens. So we know as human beings that what happens in our lives affect us in some way, and we sort of understand that. So that narrative isn't new. What's new is the understanding of what's underneath that, what the biology and what's going on in terms of our health. So over the last century, lifespan nearly doubles and health span increases dramatically. We have more resources and flowing to the end of the lifespan, so that there's all this money flowing towards the end of the lifespan. And it's not just Medicare and Social Security, but it's everything else. So cruise ships, white belts for old guys that are going to play golf, and white shoes and golf courses. I mean, there's huge amounts of money, capital flowing to the end of the lifespan, and that means that we don't have as much early on. We have this problem of, having more old people than young people, and children no longer are expected to walk in their parents' shoes anymore. And I'll come back to that when we talk about life course. So how does this look from a life course health development standpoint? Well, what we've seen is that over this time period, if we think about how our health develops and our capacity increases and goes down, I'm right about here. Many of you are here. We don't have many young people here, but you grow and you develop. You grow and develop your capacity. You go into this plateau phase, and then you start down in terms of your, what happens. You can think about where you fit on this thing, right? What's happened is that the lifespan has increased from 40 years to near 80 years. Our health span has also increased, so that people actually are living generally healthier and longer. So, that's the 60 is the new 40, and the 80 is the new 50, and whatever it is. And also the performance span has increased. IQ of the population has actually gone up 15 points over the last century. You wouldn't know it, but, but it actually has. And so we see these changes in this curve of health development that have happened over this time period. And what we've seen, and this is from the Healthy People 2020, is that we've started to think about the determinants of health, about all of the social factors, and you can see that they've now put life course into this. This is the first time we're starting to think about this. This is federal government thinking about how we get best outcomes. And the basic idea of this model is you can go into high health trajectory or low health trajectory when you go, and it's the number of risk factors pushing down and the number of protective factors pushing up. So people that live with lots of risk go into a low trajectory. People that live with less protective factors go into a high trajectory. When you go into a high trajectory or low trajectory, you become symptomatic at 60. So it basically accelerates your aging process. You have heart disease and diabetes, obesity, various other mental health problems at 60 versus, becoming symptomatic with problems at 80. And what's important is there's a huge amount of money spent during this time period because people are getting sick earlier than they need to be. And part of what we need to be thinking about is how do we improve the protective factors early in life and decrease the risk factors early. So this has been sort of embodied in the IOM report around children's health that came out in 2004, that came up with a new definition of health and said, that health isn't just a capacity, but it's a developmental process. So they started thinking about what health development is and came up with this definition that children's health is the extent to which individual children and group of children are enabled to develop and realize their potential, satisfy their needs, and develop their capacities. And the important issue is about development. In fact, Michael Liu and I came up with a definition of women's health, a developmental definition of women's health also. So to think about how does women's health develop? How does women's mental health develop? Developmental way of thinking about it. And so this is it's trying to bring that kind of framework. And so how does this play out? Well, you have kids that can go into delayed or disordered or at-risk trajectory. Poverty pushes down, lack of health services, toxic stress, and you have protective factors. So parent education, reading to your child, appropriate discipline. And the name of the game right now is how do we have more protective factors, less risk factors, because we want more kids going into a healthy trajectory. And from a societal standpoint, from a city standpoint, from a community standpoint, this is what we need to be managing towards. What are our big levers that we have that can push and shift the curves in this way? And a lot of what I'm talking about is not about individual people that I would see as a clinician or an obstetrician would see or a therapist would see, but it's about how do we change the big things? How do we shift the curves on this? And we're using this life course approach for all kinds of things. So this is just thinking about looking at obesity now. So we start to think about if we want to prevent obesity, we have to think about maternal nutrition and growth and toxic stress during pregnancy. Have to think about stress. So that's a whole different way of thinking about the conditions that we're dealing with. The reason why this is important, and I'll just breeze through this, is it really represents a change in our model of how we think about things. We started off with a biomedical model that was informed by simple genetics, by simple ideas like germ theory, that got coughed on and got sick, and ideas that, when we cut people open and saw that they had a tumor, we thought, oh, the tumor must be causing all the problems. So it was sort of pretty simple cause and effect. And that was the biomedical model. And simple, mechanistic, and linear. But then we do all the studies, like the Framingham study, that showed it wasn't just bad genes and bad luck that caused heart disease, but it was what you ate, if you smoked, exercise, and all these other things. So there were all these cumulative influences, and then there were all these behavioral issues. So it changed our model from being a simple biomedical model to this biopsychosocial model, which is the model that most people buy into today. And that's a dynamic model and it looks at multiple factors affecting your health. But what's happened over the last 10 years or 20 years is we have all this work that's gone on about epigenetics and understanding that certain things that happen to you early in life actually change how your DNA is read and coded. It changes how your metabolism develops. There's all these national birth cohort studies that have taught us a great deal about how health develops. And so now we have this life course model, which is more complex. It's more about the relationships of multiple factors. And it's dynamic and it's more developmental. So we're moving in this direction. And there's a paper we wrote in the Maternal and Child Health Journal called Life Course Health Development, Past, Present, and Future. And I'll make sure that you guys get that. You can just download it off the web, but I'll give it to you so you can distribute it. But it has this diagram and it has the evolution of it. So the principles we lay out in that is that these principles of life course health development is that health develops is an emergent property of all living systems. That it's what happens is health is a result of all these factors that happen and emerges out of those things. It's not just a static thing. That's what developmental processes are. That health develops continuously over the lifespan. It's about nonlinear, multiple interactions of multiple factors so that, what's happening early on in your life, the traumas that you've had, they compound over time. They're reinforced by other things. So the trauma that you talked about in terms of that your mother experienced, that you internalized, were so obviously increased by racism and other kinds of factors that you experience, so that those all go into and create pathways of development. That health development is highly sensitive to the timing and structuring of environmental exposure. So if you have a kid that's growing up in an environment where there's lots of stress at home, and he lives in a neighborhood where there's violence, where the schools stink, and on and on and on, that's structuring the environment for that child. And the timing of those influences are important. There are a whole set of evolutionary issues that have to do with this that I'll perhaps talk about around adolescent health and mental health, and the timing of these issues are really important. So that just real quickly, this is just looking at brain development, and part of what I'm trying to make the point here are these trajectories. So here's a newborn brain, here's a 6-year-old brain, here's what the brain development looks like in terms of, at birth, by 6 years of age, you're almost at your full brain weight. This is looking at glucose metabolism in the brain and synaptic density. And the point here is that you see the same curve over and over again in terms of how potential develops. What's really important to recognize is that how the social environment changes the aura potential. So this is looking from the famous Hart and Ridgely studies. and it's looking at the vocabulary development in children by 36 months of age. What you see is by 16 months, the social environment is clearly, obviously affecting how children are developing. So by 16 months of age, you have very different vocabulary development. College-educated parents, their kids have close to 1,200 words at 3 years of age, and the parents that are living in the housing projects are about half of that. So you're seeing these trajectories that are going to go on and be their SAT scores that are sort of set and being happening. And this is not just the functional things that we're seeing in terms of how the brain is functioning as manifest by vocabulary. And this is the so-called 30 million word gap. Have you heard about this? The White House had a big 30 million word gap so that now everybody's talking to kids more and singing. And, it's not just a 30 million word gap. It's also a 30 million hug gap. And it's there are lots of differences that are going on. But what we've seen now with the brain scan data that's been done is that you see the total gray matter of children by social class also, so that actually it's not just the functional aspects, but it's the structural aspects of the brains that are different in these kids. So that this is the way that social class is affecting how brains are developing. And to me, this is really important, and it's not that this is deterministic, in a way, but unless we change things, it is deterministic, If in fact kids are going to continue to live in poor environments and nothing's going to push up on their trajectory, they're just going to stay in a lower trajectory. We know about pathways to resilience. There's a huge amount of research. This just summarizes all the factors that we know that lead to high personal achievement and sustained growth. We're all interested in resilience and what it leads to resilience and effective self-regulation, effective learning and all. So we have a good sense of what that looks like. And we also have a sense of what happens when things don't go right. So when kids have problems early in life in the first decade, by the second decade we know that you see more school failure, teen pregnancy, criminality, substance abuse, anxiety, and other mental health disorders. And it plays out right across the lifespan. So one can argue that memory loss, premature aging, Alzheimer's disease is a problem of early childhood. It's not just a problem of old people, because these are things that are cascading across the lifespan. And what you're going to hear from Vince Folletti about adverse childhood experiences, this is just looking at the number of adverse childhood experiences and adult depression. So you see that you have a five-fold increase in depression. You have 5 or more adverse experiences. This is looking at heart disease from Folletti's work. We know about stress, and Jack Shonkoff has made this really clear about the role of toxic stress. You have positive stresses in your life that everybody needs to move forward. We have tolerable stresses that we can have when someone dies in our family or other things that happen, and we're in a caregiving environment that supports us, and we learn to deal with those tolerable stress. But we have toxic stress when we have stresses that are strong, prolonged activation of our stress response systems and have to do with precipitants that are uncontrollable, unpredictable, and happen over and over again. And what we know that toxic stress does is it affects how our brains develop. It affects the midbrain and our abilities to form affiliations and relationships. It affects the prefrontal cortex that has to do with executive function and memory, impulsivity, and it has to do with the HPA stress response. So we know that these things are getting under the skin, and it leads to different health behaviors and chronic disease. So the science of this is pretty well worked out at present, and you're going to hear more about this, I think, later during the day and how it affects individuals as they develop. We know that that this is looking at the brain scans of a healthy person. This is a person that has been severely abused and neglected. So you actually see that the temporal lobes have been basically taken offline. So the emotional parts of the brain are being disconnected as a result of the abuse. And fortunately, severe abuse is rare, But maternal depression is common, as you know, higher rates in inner city poor single mothers, multiple impacts, treatable. And what we know is that depressed mothers, and this, you all know this, express less positive, more negative affect, are less attentive and more disengaged. When engaged, are more intrusive and controlling in terms of their children, and fail to respond adaptively to the infant's emotional thing. So that, rather than that, you've seen I say Fred Astaire and Ginger Rogers kind of, because I'm old, but that dance that goes on between mom and baby, that doesn't happen when mom is depressed. They don't respond in the same way. They're not responding contingently to the child in an adaptive way. What do you see in the kids? You see shorter attention spans, less motivation to master new tasks, elevated heart rates, elevated cortisol, reduced EEG activity. So you see this in the brains of them in terms of what's happening. Interestingly enough, you also see this same response. I watched this in an airport recently when I watched a mother who was absolutely wonderful with her baby walk into the airport, sit down, put the baby out, put her own, about 10-month-old, start playing with the baby, and everything was all perfect. And I wanted to take out my iPhone and just sort of film it, because I could have used it in my child development class of the, and you could just see her frontal cortex and the baby's frontal cortex, and it was just this dance going on, right? And then her mother called, and she picked up the phone, and she said, "Hey, Mom, how are you?" "Yeah, my flight was delayed. I'll be there in about 2 hours late. Hold dinner for me, blah, 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 blah." And she's still playing with the baby. Baby's still laughing, playing, And then she says, "All right, Mom, see you soon," and takes it off, and then she goes into the iPhone BlackBerry prayer pose. And she starts texting. And as she starts texting, she gets completely flat-faced. And what I watched in that baby is that baby started to try to engage Mom, and Mom wasn't looking. And she's texting, and the baby's starting to get agitated, and the baby finally goes and just looks up at the thing. And it was exactly what you would see with a depressed mom or a drug addict mom. But the drug, was this. Okay, that was the drug. And what was interesting to me about this is that this happens all the time. Now, is this little baby at risk for anxiety disorders? I don't know. I saw one snapshot. Was this a great mom? Yes, she was a great mom. And would anybody think what she was doing was abnormal? No, because it's pervasive. That's why we're turning the heat up a little bit all the time, because we're doing things that turn normal women, normal mothers, into drug addicts some of the time. Inadvertently, because that's part of our culture now. I wrote an editorial about this. I got a lot of crap from people, And I show this. You can't see it. You'll have all these slides, so you'll look at this. This is from a wonderful study that was done in the UK, and it's looking at the development of mental capacity over the lifespan, looking at early home experiences, emotional, executive function, drug abuse, the whole gamish. And it looks at all the interactions, relational issues, all the cultural issues, the biological issues, but it shows how all this is connected. And they brought a couple hundred scientists together in the UK to look at this and write papers and say, hey, it's all connected. And if we want to improve the mental capacity of our elders, we have to start early and make those investments early. Now, I'm going to shift gears here quickly and talk a little bit about mental health disorders across the lifespan. And what you see is this process. 70% of mental health disorders that'll happen any time in life happen before the age of 25. And recent estimates suggest that over 30% of adolescents have mental health disorders. So this is a pretty critical period of time in terms of the development of mental health problems. It's from age 10 to 25. Now, 25, you might not be thinking of it as adolescence. It's a young adult, but adolescence starts way early now and ends very late, as any of you who have kids might know. So we look at the age of onset of all these different disorders, and you sort of see whether it's anxiety disorders, substance abuse, anorexia, major depressive disorders. They're all happening pretty early in the lifespan. And what we need to realize is that how adolescence has changed. Adolescence is 5 to 10 years after the onset of puberty. Evolution and the appearance of adolescence as a distinct period of human development happened about 60,000 to 125,000 years ago. There wasn't always this period in human beings, or whatever we were called then. And it contributed to reproductive gains because as people began to live together in groups and didn't want to tear each other apart and wanted to trust each other and reproduce together, had to create a lifespan or the life course in which you would allow girls to walk in their mother's shoes and boys to walk in their father's shoes, and to be relatively safe so that they could practice what it was like to be a mom and practice what it was like to be a man. And this period of apprenticeship was really important for complex social, political, and cultural relationships. We evolved because we created something called adolescence as this training ground for adulthood. And it gave juveniles ability to walk in their parents' shoes. Well, what's happening to adolescents? Well, we have this acceleration of biologically what's happening. So puberty is much earlier than it used to be. And whether it's nutrition, chemicals, cow's milk, I think it's because of all the sexualization in society and everybody's, that it's sort of a mental thing that's happening. But we have this gap in between the psychosocial and the reproductive maturity, that I love this quote, that we're chronological hostages of a time warp between biological age and social. And so we have this accelerated development of adolescence in terms of being sped up socially. We're hurrying children up the slope of development. You have to grow and develop faster. My daughter is learning stuff in 9th grade that I didn't do till I was in 3rd or 4th year of college now, and the kinds of things that they do. And it's all very nice and cute and great for competing with the Indians. A lot of kids that fall by the wayside because as we make that developmental thing in which you have to go up, there's no handrails anymore. It's harder and harder. We have unprotected development, the traditional family, religious, social buffers that were wrapped around the psychosexual vulnerability that happened once you went into puberty, before you got married. A lot of that's being stripped away. And kids go into puberty not at 15 and then get married at 18, which was in traditional societies. They go into puberty now at 11 and 12 and don't get married till 25. So instead of having to protect 3 or 4 or 5 years with religious and cultural and family traditions, now have a 15-year gap, and we've unwrapped all those social protections and stuff, and they're now being, and I'll come to it, colonized in a way. We have segregated development that traditionally, kids were in adolescence. It was a training ground for adulthood, but relatively socially segregated. So kids are raising themselves. Other adolescents are raising. They're part of this adolescent culture. And age segregation and group identity, no longer walking in parents' shoes. So there are big changes that happen. American form of capitalist consumerism requires well-developed, needy consumers, and the big focus of that are on adolescents. That's where you learn how to be a consumer. And everything's marketed to them, and all the sex roles and everything else. So we've unwrapped the parents and the religion and everything else, and we've sort of let Madison Avenue and the marketers take over to raise children, raise our adolescents. And we have this extended development so that we have it, and it's harder for them to become independent as we extend this. So this is just looking at the decrease in puberty. So going down from the 1860s, and these are across a bunch of countries where it's about 15 to 16 years of age. 1960s we're down at 13, and this has continued to go down. This is a big change. This isn't a little change. This is huge. This is the frog in the This is a frog in the pan of water. The temperature's going up, but we're not paying attention to it. What's going on? This is just looking at independence at age 20, and males in 1960, 65% were independent. Males in 2000, 31% are independent. It's a big changes. And we're learning more about the teenage brain and how the brain develops. This cartoon says, young man, go to your room and stay there until your cerebral cortex matures. And what we're understanding is there's a huge amount of brain development that happens during adolescence, and it actually probably as much and as significant as happens in adults. And we're understanding, just looking at the brain images, that these are some that were done by he was at UCLA, now he's at USC, Paul Thompson. But you sort of see this resculpting of the brain that's happening from age 5 to 20 years, and I showed you those trajectories. There's a huge amount of change that happens. And we're understanding that childhood adversity leads to poor adult outcomes and toxic stress, but we're understanding there are all these maladaptive behaviors that start early in life and just prolong on. So it's not that, the focus isn't just to fix adolescence, but we have to start with early childhood also. And this is just, which I'm sure you're all well aware of, that maternal stress during pregnancy and the focus that it has on the development of the hypothalamus and the whole cortisol releasing apparatus, and I'm sure Cal Hobel will be talking about some of this later, how it actually affects the development of certain parts of the brain and leads to adolescent anxiety and depression. This stuff is all connected. So what does this all mean in terms of our healthcare system? So I'm just giving you a sort of sense that we have to think about life course. We have to think about how this is connected. There's this period of life course called adolescence where there's a whole lot of stuff going on that sort of sets the stage. And we have to understand that we need to think differently about this. I'm just racing forward because I'm realizing time-wise. Okay. Because I got to get to the punchline, right? So I'm going to talk a little bit about how to think differently about this. And there's an article that, again, I left in the car, but I'll bring, that we just published a couple months ago in Health Affairs. And it's about the 3.0 transformation framework. And you're going to ask, okay, if there's a 3.0 transformation framework, what was 1.0, right? And what's 2.0, right, if we're moving to 3.0? Because you might have missed those, right? So the story goes like this. There's been 3 eras of healthcare and 3 major transitions. The first era was focused on saving lives through acute care, emergency and rescue care, and public health safety. That goes back to the 1850s to about 1950. Second era starts in about 1950 and is focused on prolonging life. And the third era will focus more on optimizing health and well-being through primary prevention, health promotion, and community integrated services. So if we go back to the 1850s, we have a focus on infectious disease. People in 1900 are only living to be 45 years of age. We come up with this biomedical model. Most of our health care is short time frames. People get sick and you treat them. Have a heart attack, you treat them. It's all short time frames. We develop our insurance-based financing. We create our medical care models. Our hospitals, our clinics are all created during this first era. And it's based on the industrial model of production, which was the dominant model of production of all of our goods and services. That's why hospitals look like big factories, okay, because that's what they were trying to epitomize. And the focus is on reducing deaths. As the epidemiology changed from 1900 to 2000 to 1950, we go from life expectancy of 45 years to life expectancy of about 65 years. So you have all these chronic diseases that start, and more cancer. So we go into the second era, which is focused on chronic disease, and we're thinking about this biopsychosocial model, so we understand that it's not bad genes and bad luck, but it's about all these behavioral and social risk factors. We have to think about things over longer time horizons, so we're thinking about, okay, how do we prevent heart disease? How do we screen for breast cancer? How do we screen for prostate cancer? How do we do things over longer time horizons? How do we manage chronic disease? And we change our whole financing of healthcare from indemnity insurance after the fact to prepaid health benefits, because we know you're going to have your cholesterol screened. We know you're going to have that mammogram. We know we're going to have, so we're paying for it in advance. We know about that. And we go to this corporate model of healthcare, and this is what we're trying to move towards now. What you've heard about ACOs, accountable care organizations. Accountable care organizations are basically just the Kaiserification of the entire healthcare system in America. It's about turning all of healthcare into something like a Kaiser. And it's about a corporate model of delivery and finance. That's what the ACA was all about. It was about the Kaiserification of the healthcare system, turning it over to markets. It's about insuring more people, but it's about changing the structure and finance of how we develop. And we're focused on prolonging less disability, okay? Prolonging life, less disability. But where we're headed is an increasing focus on optimizing the health of the whole population. And this is the life course model, because now we understand what does it take to be 80 and healthy. We understand the protective factors we need. If we do this, we can get our whole population to be 80 and healthy. And everybody can do this. We understand what it takes to do this. So how do we manage towards an optimization scenario? How do we invest in population-based innovations? And we'll be moving towards a more network production model. So this is the 1.0 system, the 2.0 system, the 3.0 system. So let me trace it back to why this is important. Here's my trajectories again. Optimal health trajectory, low health trajectory. Most of the actions early on in life in terms of the trajectories, you become symptomatic at age 55. But this is what the cost curve looks like. And this is why we're spending so much money, because you get low trajectory, you're not dying, but you're consuming a whole lot of resources, and it costs a lot more. Go into a higher health trajectory, you have a different cost curve. Why is this important? Because the entire refrain of the entire health reform in this country was a refrain around what? It was about bending the cost curve. And it was as if we're going to bend the curve here. Like once I'm 63, my mother's 88, 89, we're not going to bend her cost curve very much at 89. It's very hard to bend the cost curve with somebody that has 6 chronic conditions, taking 10 medicines. You're not going to bend it very much. There's a little bit of squeeze you can squeeze out. And what I'm arguing here is that if we want to shift the cost curve into lower costs, we have to shift the health curve. And we have to move from a 1.0 system that waits till everybody is sick and shift upstream, not just to a 2.0 about prevention of chronic disease once they happen, but what's a 3.0 system? So how do we move upstream? How do we move upstream to the social, cultural, other factors that affect health? But how do we move upstream developmentally early in the lifespan so that we can do this differently? So this is a very different way of thinking about how we frame our health care, our health policy, and what we're trying to do. The Centers for Medicare and Medicaid Innovation took our 3.0 model and tried to say, okay, what would the healthcare system look like if we were moving in this direction? So what does a community integrated health system look like? We started to think about what's the logic, how does the logic of the health system change? So, our definition of health, old logic, new logic, what's the goal of the health system? It's about optimizing. What's the client model? It's no longer the individual. What's the individual, population, community? What's the health production, life course? So there's a whole different mindset. It's a different operating system. How does that play out? Well, let me just show you again something that you're probably all familiar with. This is the work that Michael Liu and I did looking at life course and thinking about black-white infant mortality differences. In our previous way, we had these different reproductive trajectories. But what we did is we thought, well, we'll just wait till pregnancy, we'll do prenatal care, and if we just do enough prenatal care, we'll somehow get everybody healthy. And it ignored the fact that the reason why women who were having poor birth outcomes had to do with poor nutrition, stress, abuse, tobacco, poverty. There were a whole set of issues, and they didn't start in pregnancy. They didn't start in pregnancy, and I learned from Cal years ago that when looking at women who deliver prematurely, they have sky-high CRF levels and other stress related things. That didn't happen during pregnancy. Those happened a long time. So what is a life course model? Well, we start thinking about how do we improve things over the entire lifespan. If we're thinking about mental health issues of women, how do we start early? Where do we start? How do we do this differently? So if we're trying to do this, we have to think about things. We have to think broadly about not just the health and education, social services, what happens around immediate environment of the woman, the people that touch her, but also what happens in their neighborhood, family. So you're standing behind me because you want me to finish. Anyway, I'll show two more and then I'll be done. What this is showing is, here's a low trajectory, here's a high trajectory, here's a nurse-family partnership, family resource center, there's Reach Out and Read, Triple P, medical home, school readiness. What I'm showing you here are different services, and if we horizontally link them, the way that Hope Street Family Center is linking them, or the Magnolia Community Initiative, or the Mar Vista Family Center, or the Westside Children's Center. There are all kinds of places trying to bring all this stuff together and link it up. And then to link it up horizontally over time. What have I done around here? What I've done is I've created a scaffolding around this higher trajectory. And just like this building has a scaffolding in it, why do we have scaffoldings in the building? Because we don't want them to, we got these things called earthquakes here, and so we build our building with building codes because there's earthquakes happening, and we don't want them to fall down, right? We need to build our systems for children with building codes that keep them standing up. And we have all these children that live in communities that have earthquakes rolling through their lives on a daily basis, yet they live in structures, they live in a community environment without the building codes to support them. So we need to think about what is the social service scaffolding that we need to have to support these higher trajectories. And I was just going to show what a 3.0 school health system would look like. How do you take school health centers and make them 3.0? So we've thought through 3.0 everything. What does a 3.0 health system look like, and how do we move forward? So just to conclude, I thought I'll just show this one thing. The Magnolia Community Initiative is thinking about how do you do this population-wide? How do you think about a whole area of Los Angeles? Not how do you put one service in place that takes care of 100 or 1,000 kids, but how do you go at scale? How do you work at scale? How do you go for all 35,000 kids? And I just show this because what we've done is we mapped the children's social competence, which is in the green, and this is vulnerability and social competence. And what you can see in the pink here is the maternal depression risk, neighborhood by neighborhood. So this is very different. When you can go neighborhood by neighborhood, and I can tell you that 26% of the women have depression in these neighborhoods, and you have kids with these things, we start to connect what's happening in those children's environments and the parents' environments, and we bring health and mental health and education, everybody together to sort of say, okay, how do we deal with this? What do we do? It's probably not Zoloft in the water supply, right? But there's something that has to change, that we have to deal with it at a neighborhood level and community level. And we're starting to do this around the country. We're doing this through an initiative called TEX, Transforming Early Childhood Community Systems. We're starting to do these kind of measurement and mapping. So if we're going to move forward, last slide. The maternal and child health community needs to really focus on what's our 2025 vision. How do we transform things? Not how do we just fix and patch and the broken pieces, but what's our transformation strategy? And how do we adapt this 3.0 framework? How do we make the unnecessary catastrophic loss of human potential, that brain drain that I showed you in the first 5 years of life that's happening to a large percentage of children growing up in under-resourced environments? And so how do we create this child transformation framework? And there's a group of us working across the nation on something called the Child Health System Transformation Initiative that's trying to bring together folks from across the country and look at places that are ready to say, okay, over the next 10 years, we're going to transform our children's health systems, and we're going to make sure that all of our children thrive. And we're going to commit ourselves, our children's hospitals, our clinics, our schools, our WIC sites, all of our services, and we're going to make sure that our children, Milwaukee is moving in this direction, Cincinnati's moving in this direction, San Diego is moving in the, so a bunch of places starting to do this. And this isn't about the individual small levers anymore. It's about the big levers. It's about a social movement. It's about a campaign. It's about elevating this so that it's not about individual people, but it's about all of us and how we're going to shift the curve. So thanks very much.